Welcome to the University of Michigan Dentistry podcast series, promoting oral health care worldwide.
The body is unable to store any oxygen, and consequently any deprivation of supply is immediately life-threatening. In dentistry, there is direct competition with the normal airway passages and continual hazards of foreign bodies and other mechanical tendencies for obstruction. We would like to review with you some of the causes for airway obstruction and the remedy for those causes of obstruction in their varying degrees. We will first review the question of obstruction on a mechanical basis from posture. Ordinarily, if a patient is supine and their head is bent down or flexed, there will be a tendency for the tongue to drop back and for the airway to become mechanically blocked. The possibility of foreign body going into the area of the tracheobronchial tree is a very real hazard and may mechanically obstruct either by the presence of the body itself, if it is large, or because of the reflexes that are produced by that foreign body. Another cause of obstruction can be direct bleeding, fluids which either in the form of blood or pooled saliva may obstruct the airway. The reflexes of the airway that are protective are those of the larynx, and the vocal cords can go into direct spasm in an effort to protect the tracheobronchial tree. And laryngospasm is a very real cause for obstruction and can be very difficult to relieve. There also, of course, may be direct trauma to the trachea itself or to the laryngeal cartilage with fracture of the cartilage and mechanical collapse of the tubal structures of the airway. These obstructions then can be partial or complete. If we have a partial obstruction and there still is a degree of exchange, as noted in rather noisy breathing, crowing, audible sounds, we have a chance to do something about this to improve the exchange by attacking the airway problem directly. First, by extending the head, tilting the head back. And as we do this, there's a tendency to, again, open the airway. If we will, at the same time, advance the mandible and bring the tongue forward. This will open up the airway and relieve the mechanical aspects of partial obstruction. For the fluids that may be there and for foreign material, suction is of extreme help in clearing the upper airway of these hazards. If we also can maintain this upper airway on a mechanical basis, oropharyngeal airways tend to hold the tongue forward, and similarly a nasopharyngeal airway can be slipped down behind the tongue and maintain the opening. If we have an ability then to get this partial exchange enhanced, we would like to increase the efficacy of that exchange by positive pressure ventilation. This can be done in its simplest way in an emergency and immediate manner by direct mouth-to-mouth artificial respiration with positive pressure. If other means are available to inflate the lungs, and particularly to inflate with oxygen instead of just room air, we will have a better respiratory physiologic situation. So much for the partial situations. If we have a complete obstruction, and these measures we've talked about are not adequate, and there is no exchange, and the patient's situation is indeed dire, as they frequently will become cyanotic, retract, pull on the trachea with a so-called tracheal tug and retract the sternum, while we have a great emergency situation at hand. This can be relieved in one of three methods, depending upon the location and the equipment that is available and the skill of the operator that is at hand. If there is such a complete obstruction and one has available a laryngoscope and an endotracheal tube, why, the first of these methods in skilled hands is very effective. If that is not the case, emergency cricothyroidotomy may be considered, or emergency tracheotomy can be considered. The situation of endotracheal intubation we will consider first, and here we refer to the direct passage of a tube into the trachea in a manner that first visualizes the cords and then inserts the airway. Its advantages are, of course, that it is rapid and safe. There is no bleeding involved. It provides a seal so that the tracheobronchial tree can be protected by inflating a cuff that is around the tube and seals off the tracheobronchial tree from any secretions or other problems that might leak down there. So the intubation situation is a very safe, rapid means to secure an airway in a patient who is obstructed. The disadvantages of this situation or its limitations are that one has to be skilled in passing the endotracheal tube. Sometimes there is so much spasm and muscle resistance that the intubation may be difficult, and it may require muscle relaxants, which in themselves are quite hazardous, and one must be skillful and be able to provide oxygen for this patient. Another of the limitations of intubation as a means to maintain an airway are that the pressures that are produced by the tube and the cuff tend to produce necrosis and inflammatory reactions around the lining of the trachea, and in spite of deflating and inflating the cuff, it really should not be maintained for more than 48 hours. So we have considered the advantages of endotracheal intubation, and now we will look at the specific technique that is helpful in the direct passing of the endotracheal tube. The obstructed airway is an acute problem and must be relieved immediately. If there are trained personnel and equipment available, the endotracheal intubation may be satisfactory. However, in emergency situations, particularly in the dental office, these equipment and personality facilities will not be available in most instances. As a result, we must turn to the simplest and easiest way to get into the airway at a level immediately below the vocal cords and establish an airway for the desperate situation. A cricothyroidotomy is the emergency avenue to the trachea. It is life-saving in obstructions that cannot be relieved mechanically by head tilting and advancing the tongue and mandible. The target for the cricothyroidotomy is easily located. If the patient's head is extended, one can have a forward thrust for the trachea. If we can simply look at that at a moment on my voice box, if the head is extended back, the mandible is tilted up, this brings the trachea forward. As one palpates in the midline, one can feel the thyroid cartilage, the Adam's apple, or voice box. In the midline, there's a notch. If one presses on that notch and then moves down to the first depression, moving down, one's finger drops right in to the first space. That is the space of the cricothyroid membrane. That is the target for gaining entry and is the closest distance between skin and the lumen of the trachea. So this is the avenue which can be reached in one of a number of ways. A very simple emergency way is with this approach with a needle or trocar of 13 or larger gauge, which makes a direct penetration through the skin and through the fascia and musculature into the cricothyroid membrane, which is very thin, and immediately one is in the lumen of the trachea. Having established this, a larger opening can be established and maintained with a trocar as shown here, or if you don't have this equipment, many a life has been saved with a jackknife thrust into this area and turned sideways to maintain the opening, or such things as the cap of a fountain pen or any kind of a tube thrust into such an opening to temporarily maintain this opening for intake of oxygen. This then is the simplest, most rapid manner into which the trachea can be opened. It has some obvious disadvantages in that it is too high, it threatens the vocal cords, it is nothing that can be maintained for any length of time, but nevertheless it will fulfill the immediate need of getting oxygen into that patient's lungs, and then later one can look at other means to maintain it if the obstruction cannot be relieved. If the obstruction can be relieved, the foreign body retrieved and so forth, then the normal avenue can be reestablished, and of course the cricothyroidotomy opening immediately discontinued. But this is the emergency avenue to the tracheobronchial tree, which one would carry out in the event of an emergency. Another emergency approach, again where there is the equipment and some facilities are available, will be a tracheotomy. The tracheotomy can be an emergency procedure as well, but it is better to take your time, if you can, in the maintenance of the opening into the trachea, particularly when such maintenance satisfies some longer-term requirements for the maintenance of the airway at this level. The tracheotomy is performed through the tracheal rings and is maintained at about the third and fourth tracheal ring, and we can consider some of its advantages. We will bypass then the problem and establish a direct opening into the upper airway below the level of the cords. It is possible to seal this off with a mechanism of cuffs around the endotracheal tube that can be inserted, or the tracheotomy tube that can be inserted in this manner. And we can eliminate also the dead space of the upper airway. This is particularly true in certain forms of lung disorders where the dead space of the upper airway makes exchange difficult, and where in situations of respiratory failure one wants to get oxygen to the lung in sort of a short circuit manner. There are many other reasons for the maintenance of an airway through tracheotomy that deal with surgical problems and trauma problems and so on. But the advantages are obvious. This is a way to maintain life easily without depending upon the normal integrity of the structures above this level. We can exchange or breathe through a tracheotomy tube then with no resistance, and life can be maintained in spite of the fact that the face may be crushed or things may be obstructed entirely above it. There are a few disadvantages to tracheotomy. It does require an element of anatomic knowledge and skill, some of which we'll review in just a moment. There are some complications to the performance of a tracheotomy. The neck is full of significant anatomy, and the head must be maintained in a firm, extended position with the trachea thrust up and the head stabilized so that you can stay in the midline and avoid any lateral excursions into the carotid sheaths and where the major vessels are located. The trachea in the tracheal ring area is incomplete in circumference insofar as the cartilaginous rings are concerned. And therefore, in making an incision, it's possible to plunge through and go through the separating partition between the trachea and esophagus to produce a tracheoesophageal fistula. Highly undesirable to have esophageal contents leaking into the trachea, and so obviously this should be avoided. Where the tracheotomy is performed, the wound is left rather loose so that leaks around the opening into the trachea do not allow expelled air to dissect into the tissues to produce the subcutaneous emphysema, or to extend even further with another disadvantage in the production of pneumothorax or pneumomediastinum. Now, the dome of the lung can extend up into the area of tracheotomy, and once again, if you stray laterally, you can nick the pleura and produce a pneumothorax. Or the expelled air from around a tracheotomy opening can dissect down into the mediastinum and then go out into the lateral area and collapse the lung in that manner. So these are a few of the disadvantages of tracheotomy. There are some concerns about the maintenance of a tracheotomy opening that we can discuss at a later time, but the technique is worthy of review since it must be done accurately, and we'll look at a film on the technique of tracheotomy. Having just reviewed the technique of tracheotomy, we will look again at the target area to review certain of the important anatomic considerations. Here we see the midline incision has been made through the musculature and fascia, and the large hemostat has been placed to spread the musculature so that we see the tracheal rings. The reason that the third and fourth tracheal rings are the target for making the opening is that the cricoid cartilage above is the only one that is a complete ring, and as a result of that, it maintains the complete circumference of the lumen of the trachea, and it stabilizes it so that we don't want to let that collapse, which it would do if we tended to cut it. Therefore, we keep the tracheal opening low, and the target area is down at the level of the third and fourth rings. The opening through the cartilaginous rings can be made in a number of manners, as we've discussed in the film on technique, but let us look at that opening for a moment, and we will see here stabilization of the cartilage. This can be done with a hook or with a clamp. The important thing is that it be stabilized, that it be in the midline, and that the opening can be maintained. Now, this is often done as a trap door. Instead of cutting out a segment here of the cartilage, it may be left hinged at its lower edge, and this hinge can be sutured out to the skin, and that will tend to maintain it, which is particularly helpful if one needs to change the tracheotomy tube that is put in this position. The problems of tracheotomy in children are particularly unique because the structures are small. The trachea tends to be softer and more difficult to locate and more difficult to control. The possibilities of transecting the trachea are very real in the child, and therefore the opening is not made, the cut is not made horizontally ever as you try to open into the trachea. You don't go between the rings, you go through the rings and vertically so that there's no chance of transecting the trachea across its cross-section. Another of the reasons for making the tracheotomy low, as shown in this diagram, is to stay away from the vocal cords. That's one of the reasons that cricothyroidotomy cannot be maintained. It's too close to the cord level, where irritation and possible stenosis, which is particularly a problem in children, might occur. The maintenance of the tracheotomy is of critical importance. Most tracheotomy tubes are double layered. In other words, they have an inner cannula that slides inside, and that inner cannula can be removed and cleansed. The secretions of the trachea, since they cannot normally be swept up and expectorated through the upper airway, tend to cake on the inside of the tracheotomy tube. So regular cleaning of a tracheotomy opening is of extreme importance. We mentioned the edges are kept loose, and these wounds, at the time that the tracheotomy can be discontinued, granulate in spontaneously and heal without any requirement of any detailed closure of this opening. The crisis of airway obstruction necessitates immediate relief. The possibilities of relieving this obstruction will depend a good deal upon the situation in which one finds the victim. The possibilities of constituting a new patent airway for exchange from the lungs may be inclusive of three opportunities. One would be the availability of a laryngoscope and an endotracheal tube, and the ability to pass that endotracheal tube through the vocal cords and into the trachea. The situation where such equipment and skill is not available and the victim is in a critical situation will call for the avenue for emergency entrance to the trachea via the cricothyroidotomy approach. This is at best a temporary mechanism for the relief of the obstruction, and as a secondary procedure or as an alternative procedure where equipment and supplies are available will be tracheotomy. Tracheotomy is the preferable way to open into the tracheobronchial tree to relieve obstruction, particularly when this obstruction must be relieved by this mechanism for some period of time. We have then reviewed with you the problem of airway obstruction and the management of such airway problems by a number of different life-saving methods. In a life-saving emergency, priorities need to be established, the first of which will be assessment of respiration and the adequacy of the airway for that respiratory exchange. Once the airway has been established and oxygen is being delivered to the lungs, one can turn attention next to circulation. This would begin with the assessment of the heart and the heart's action, and if there is no heart action, one would turn immediately to closed chest cardiac massage for compression in order to circulate the blood that is there. But if there is heart action, then one can assess the blood pressure, and in a situation that reveals shock or severe hypotensive states, one must think about the administration of medications and the administration of fluids. Now, the most rapid and effective way to do this will be through the intravenous route. And with the intravenous route, we have a mechanism where we can deliver the fluids and we can deliver the medications so that they can hit their target sites, whether these be the brain or the peripheral vascular system or whatever we're trying to affect. They will get there most rapidly through the perfusion that can be achieved by this intravenous route. The different ways in which we can establish this intravenous route are most simply the method of venipuncture. One would attempt to establish standard venipuncture with larger gauge needles through which fluids can be administered. Routine venipuncture is something that every dental student has established and as a technique for delivery of premedication agents, and he should have this technique mastered so that in an emergency he can, as soon as possible, establish the intravenous route. Now the problem with this is that slipping needles and catheters into veins in a patient who is normotensive and has an adequate blood volume and an adequate peripheral fill of fluid keeps the veins dilated, so it technically is feasible. The problem is that when a patient is without blood pressure and there is peripheral vascular collapse, it is indeed very difficult to get into a vein. This becomes very difficult also in children whose peripheral veins tend to be very small, and in obese people who have a good deal of insulation between the skin and the larger veins which we may be trying to reach. So the other opportunity that has to be considered in an emergency is a cut-down procedure. This is an actual surgical procedure that must expose directly the vein and insert the catheter into the vein lumen itself. The indications for this cut down would then be a need to maintain an intravenous route for some length of time in order to deliver fluids and blood in the case of doing battle with shock states and hypovolemic circumstance from excessive bleeding in trauma victims and the like. In hypotensive crisis where you cannot get into a vein and you need to deliver fluids and drugs to affect the peripheral vascular and cardiovascular system. One may need to do this in a severely debilitated patient where again they need to deliver fluids and other agents may be necessary over a protracted period of time, or we've mentioned this aspect of non-visibility where you can't find a target to shoot for in a venipuncture, then one selects and performs a cut-down procedure by means of the technique that we will next review in this film.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.